OsteoSignal, Episode 14. This is OsteoSignal with Neal D. O'Neal, a podcast exploring how your body's natural design connects with osteopathic science, translating complex signals into practical insights so you can truly thrive.
Welcome to the OsteoSignal podcast, where we explore how the body actually heals, not just by treating symptoms, but by restoring the signals that allow you to move, breathe, and live well. I'm Neal O'Neal, manual therapist and educator, and in this podcast, we unpack real stories, real patients, and real clinical moments to help you to better understand how health works in the human body. Whether you're a patient trying to understand your own healing or a clinician wanting deeper insight into recovery, you're in the right place. And joining me today is Brent Maryberry.
Hey there, I'm Brent, and I'm one of Neal's associates. I actually produce the podcast, and I'm just here to ask questions and to kind of dig a little bit deeper into what Neal has to present. So good to be with you.
Yeah, thanks for joining us. It's good to have you here so we can really dig deep and have lots of good questions to mull over here. Okay, so without further ado, let's get started. Okay, so today I want to tell you about a patient who changed the direction of my career. He was a football coach for my semi-professional football team, right? And his wife was the team mom. They were deeply involved in the program. One of those couples everybody admired, loved. They were just great. And one Saturday, they were driving equipment to the stadium for that night's game. A driver coming from the other direction was a diabetic and had apparently had a severe low blood sugar episode, and he drifted in their lane at highway speed. Unfortunately, they collided head-on at nearly 60 miles an hour. So his wife died at the scene, and he survived, but barely. He hit the steering wheel pretty hard and sustained head, chest, and abdominal injuries. He went through emergency care, hospitalization, and recovery. He actually had bleeding in the abdomen. He had, pericarditis is in the bag that the heart is in. He had some blood in there. He had all sorts of problems. Now, he went through all this. He went through his emergency care, his hospitalization, recovery. It was fantastic. They saved his life. It was a long recovery. Many weeks later, medically speaking, he was healed. But something was still terribly wrong. When he came to see me, his biggest complaint was severe shortness of breath. Not mild. He could barely talk without running out of air. He would speak a sentence, stop, gasp, try again, tried to get all his words out, and just run out of air. All his scans, medically looked acceptable. The doctors couldn't explain why he couldn't breathe. From a medical standpoint, the major threats had already been handled. His lungs were intact, right? He had a pneumothorax, and of course there was blood, there was air. One of his lungs had collapsed. So now, though, his lungs were intact, no collapsed lung, no fluid accumulation, no life-threatening complications remained. But still, he couldn't breathe. Okay, so this was early in my exposure to osteopathic thinking, but the one thing that stuck in my mind, something that everyone learns in first aid, is ABC, airway, breathing, circulation. So I started there. I checked, so first checking his airway. Now, osteopathically, we look at the hyoid and the esophagus and the trachea. My job was to make sure, that those structures worked, that he could work his airway. Was he just not able to get the air in or out? Did he have spasm of his throat? And while his throat was really tender and very tight, it was open. So next came, check breathing. Breathing depends heavily on the diaphragm, the large muscle under the lungs that moves downward when we inhale. And that muscle, medically, breathing requires intact nerves and healthy lungs. And the nerves to the diaphragm mainly come from C3, 4, and 5. So some people with cervical fractures above that cannot use their diaphragm to breathe, and they have to be on a respirator.
Is that like, that's part of paralysis, right?
That's part of paralysis.
Those nerves,
right. Yeah, anytime somebody's
like
that's
a quadriplegic, right?
Quadriplegic.
They can't breathe on their own. Yeah.
Exactly. So all of that was intact in him. He had injuries, but he had mostly recovered from those, life-threatening injuries. He still had some challenges, but it wasn't his neck that was causing this problem, So mechanically, the diaphragm must be able to move. And no one had checked, does the diaphragm actually move? And if it moves, how far does it move? So, of course, I examined him. I asked him to take a deep breath while I placed my hands around his lower rib cage and his abdomen to feel the motion and to see what we call the excursion, or how far that the rib cage would move. I also put my thumbs into his diaphragm as he tried to breathe in to see, did the thumbs move, downward towards his feet
With the muscle. Yeah.
with the muscle. Like as he takes the breath in, the diaphragm
Yeah.
should push my thumbs down towards his feet. And surprisingly, almost no excursion. There was hardly any motion, which, uh, after all the advanced imaging, all the hospital care, the most basic mechanical test of breathing function had never been performed. Now, the thing is this isn't something doctors do. They don't manually test the diaphragm. They have machines and stuff to do that. And while they tell people, hey, you've got your little inspirometer, take a deep breath, keep taking your deep breaths, that just tells the person to try harder. That's kind of like, hey, you can't do a squat, so do 10,000 of them, and maybe in the end you'll be able to do them, right? It's like, well, if you just can't
Mhm.
do something, doing 10,000 of them isn't going to make it better. It's just going to actually make it worse. And so for him, even though technically, medically speaking, everything was intact, he still wasn't able to use it. And it was only really something you could pick up on. I mean, I'm sure his respiratory therapist had been like, well, you're just not breathing that well. Take your inspirometer, go home, keep trying. And he kind of made his comment to as much. He says, yeah, that stupid inspirometer, I can't make it go up for anything. So for him, the muscle simply couldn't move. So
So he could exert it. It just wouldn't, for some reason, it was stuck, like your analogy about squatting,
right,
right? If
right.
you can't so it's something mechanical, like the muscles probably function, they were getting the signals to contract, but
Right.
something was blocking the movement, it sounds like.
Right, exactly. Like if your hip is stuck, like you've injured your hip and it's just there's swelling and edema in there, you just can't squat down very far, right? People notice that, like, oh, I'm having a real hard time reaching down and touching the floor, or I go to squat and I just can't go down because of the inflammation and the irritation, the muscle spasm, the other things going on in the hip. In this case, it's in your diaphragm and in your abdomen, and it's like, well, what could be doing that? Well, actually, there's a lot of things that cause that. So I performed a very gentle manual release to help free the diaphragm on one side, then on the other. Nothing dramatic, nothing, just restoring motion. And suddenly the coach gasped, right? Huge breath rushes in, like someone who had been underwater too long and had finally surfaced,
Wow.
right? And his face, I hadn't really noticed that it had been a little bit of a ruddy, darker color. It really shifted from that purplish tone to a deep red, and then gradually to a healthy rosy color as oxygen kept flowing in. It flowed in. He just kept breathing, these deep breaths, like he was a man starved of breath, and almost like his lungs suddenly realized they were allowed to expand again. And then he looked at me and he said, "That's the first time I've been able to breathe since I lost my wife." And he started to cry, and it was a very
Wow.
moving moment. Yeah, it was. It was very touching. I knew his wife. She was a great lady, but the thing is that, through all this medical care and all this, the man couldn't breathe functionally, really. He couldn't walk very far. He couldn't speak. He couldn't have long conversations. He was having all sorts of difficulty. And yet medically, there was really nothing to be done. But here's the problem is that there are several structures. The diaphragm's a midway point of the body, and there's a lot of things going on there. You have your aorta going through there, and obviously it had the chest trauma and the abdominal trauma, and the aorta, is part of that, and obviously had been injured in this whole situation. So that goes through the left side of your diaphragm. Then your venous return, all the blood returning in the veins goes through the inferior vena cava on the right side. So then the right side of the diaphragm has to work properly. Otherwise, you can't get blood back properly. Certainly your stomach on the left and your spleen on the left, he had suffered trauma. His spleen had gotten enlarged. His liver had been injured in this accident. Then also just the intestinal tract, right? The large intestine actually hangs from the diaphragm on either side from a very thick ligament. And those ligaments had just in the trauma and the injury had just become rigid. And that's what was holding his diaphragm from being able to move anywhere. The diaphragm just couldn't push against all these, still slightly inflamed, but stuck down structures, right? That the edema from the swelling from these structures had caused them to stick to everything around them, including the diaphragm. And then that's where he'd lost the excursion of his diaphragm, his ability to really take a full deep breath. So
Wow.
Yeah. So it's a, and it's one of the things that you think, oh, well, okay, well, this is just this horrible injury, and only in those cases would this be a problem. And surprisingly, obviously, like I said, this was early on in my career. Since then, I've had many reasons to look at people's diaphragms. Obviously, this got me to very, very early on in my career key in on this problem. That it's amazing how many times I will go to treat a patient and one side of their diaphragm is not firing fully. Right. So there will be some motion, much like his. Now, his was bilateral. It was really affecting his life. And so people can make up for that. The problem is if you're breathing, and I'll just point out that you breathe 23 to 32,000 times a day, right? That's an average. So
Wow.
that's a lot of time. So if you do 23 to 32,000 repetitions of anything and it's off even just a little bit, there's going to be serious consequences for that.
There's a cumulative, deficit that's going to affect you for sure. Yeah.
Right. I mean, people with scoliosis, people with postural problems, not just people who have shortness of breath or even know that they have it. People who've had side stitches when they were younger, and they say, "Oh, I don't have side stitches now." It's because they've become so stuck in that posture, they never challenge their diaphragm there, and so they don't feel the side stitch anymore because they don't move there. Right. So these are all
Would we
indications.
would we say, that they're adapted
Yes.
or
They've adapted to
compensated?
this. Right. They've
Okay.
adapted, and at some point they have scoliosis that's somewhat locked in there, and it's starting to compensate. If after a while
Yeah.
they'll be stuck in that position. Right. So our job is to say, hey, look, you're adapted, but we need to make you adaptable. So we need to get that loose again so that you can reach right, reach left. And sometimes people injure their shoulder reaching in the back into the back seat, and they go, "Oh yeah, it really hurt my shoulder here." And it's like, well, the thing that helps set that up is that if your diaphragm on the right, if you're the driver and your diaphragm on the right is stuck like that, you go to reach in the back, your thorax, your rib cage cannot turn to the right because it's adhered down. So when you reach back with your arm, you have to hyperextend the shoulder. So you're going to injure the shoulder more. So people might not even realize, like, yes, other injuries come about because of this. So that's why it's so important when people come in to look at the diaphragm and say, does the diaphragm function properly? Does it have its full excursion? And does that cause the thorax or the thoracic spine to be stiff? So
Interesting.
yeah, and so that's exactly what with him. Like he started to cry, and I just sat there stunned. I mean, at this time, early in my career, I'd never seen such an immediate change in someone. And in that moment, I had realized something profound. The body doesn't just need medicine or surgery. Sometimes it needs motion restored. It needs signals restored, mechanics restored. And when that happens, the physiology follows. So from that day on, I knew this is what I needed to do with my career. I had a patient, she's from India, and she says, "Oh, you have found your dharma." And I'm like, "Dharma?" But I think what she means is my calling. I found my calling, and certainly it is a calling. I just, when I have these kind of results with patients, it just blows your mind, and you're just like, "Wow, this is the most important thing I could possibly do with my time is to make sure that patients have this kind of care and have access to it." Because again, it's not part of the medical system because they're looking for the things that are going to kill you, and they're trying to stop that. Now,
Hmm.
technically, you would think like rehab would say, "Okay, well, our job now is to make all these things work better." But that's not what they do. They just say, "Well, whatever you have, that's what you have, and we're just going to make you stronger in whatever you have." But if you're adapted and you're stuck in that position, they're just going to make whatever you have slowly worse. And then when you come
Right.
back to them and say, "Oh, I can't do this or I can't do that," they're going to say, "Oh, well, then don't do that. Give up running, give up walking, give up holding your grandkids. Just give up doing whatever it is and just accept that you're older." And that's
Yeah. Just their motto, I think, is just survive, just make it instead of thrive.
right. Instead
Right.
of
Which
thrive.
is, I think, the osteopathic approach is don't just survive, but thrive. Actually become more adaptable.
Exactly. Exactly. So this is what I've been doing with my career. And now I want to make sure that I share this with other people, not only patients, but other therapists who maybe, you know, everybody wants more tools. I mean, I don't think there's any healthcare provider out there that's not really in it to help people. It's just sometimes you don't always have the tools. So I'm,
Or yeah, you're not aware of the tools,
right,
right?
right. Like this
Sometimes.
one
Yeah.
had been a brand new one for me. And a lot of people talk about, oh, we do this with the diaphragm, or we do that with the diaphragm. But I don't think that that's a regular understanding of the diaphragm being in the center of the body and really tying the top of the body and the bottom together, the bottom of the body together, and allowing them to function as a unit that operates in the same way and then the opposite way. and makes them adaptable to any situation they might be in, sometimes the importance of that is lost.
Yeah, I was going to ask, actually, with this particular patient, once you restored that diaphragm movement, were there maybe secondary effects that resolved themselves? I mean, his primary complaint was his breathing, but did you observe other things that were just affecting his well-being that this treatment of his diaphragm helped resolve? I'm just wondering if you had seen anything else.
Yeah, definitely. It was interesting that I hadn't even noticed that he had noticed a little bit, but he had a stooped posture. And as soon as he did this, he stood up straight, and these deep breaths he was taking, every time he would become fully upright. And he's a pretty tall guy. And, he had shrunk several inches. And all of a sudden, here's this guy, and you're like, oh, coach, I'm back to looking up at him going, oh, I forgot you were that tall. So not only did his neck start feeling better, his back felt better. He was able to get back to walking and doing the other things that also helped the other aspects of his health. So his blood pressure went down, his heart rate went down. He was able to get off some of his medications. He'd been on heart medication before that, but because he was able to go back to exercise and able to breathe properly, a lot of the stress on his system was taken away. And so now, like you said, he was able to thrive, and he didn't need all the help from the medical system. His body was functioning as it was supposed to.
Yeah, you restored his body's ability to heal itself.
Right, exactly. I mean, and for patients listening right now, it's like, sometimes healing stalls, not because tissues are damaged, but because movement and the signals are restricted. And it's an important understanding. Pain, fatigue, breathlessness, brain fog, they can all persist when mechanical function isn't restored. And that's not the message you always get from the medical, or like you go to Dr. Google, pain, fatigue, breathlessness, brain fog. I mean, those are the symptoms in a lot of different problems. And Dr. Google can't tell you, well, it's because your diaphragm's not moving, or your spine is adapted to this aberrant motion, or your hip is not fully functioning right. And you've adapted to it. So you don't even realize, oh, the problem's in my hip, not in my back. I have back pain because I have a hip problem, or I have knee pain because I have a hip problem. Patients may not even fully understand that, but we really want to educate them and say, look, I implore you to demand more of your healthcare providers. And if they don't know the answers, I'm hoping that you can push them to look further out there, maybe come across this podcast and go, oh, that's
Yeah.
interesting. Yeah, exactly. Right.
So it's not just a traumatic thing that people, might deal with breathing. Like you mentioned, childhood incident or just little things that people pick up over time.
Right. Little injuries. I
I
mean,
want to say like football, like American football players or rugby players,
soccer players.
over time they might have soccer players.
Yeah.
They
You
might
hit
have
nail.
things like this, just getting collisions might, cause a buildup of diaphragmatic inhibition, if that's the right term.
Yeah. Yeah. And the other thing, I mean, gymnastics, your kids playing on the, uh, on the monkey bars and falling off and landing on their back. I mean, who hasn't fallen down or gotten hit or something where you've knocked the breath out of yourself and your diaphragm spasms for what seems like an eternity, but maybe only 20, 30
Yeah,
seconds, right? But those are exactly the
right.
sort of things, and that might have happened so long ago, and it got knocked out of whack, but you mostly recovered from it. Mostly it came back online, and then you just went on with life. But since then, people then also pick up, well, now you have this one problem, and then you add this other problem to it, and this other problem to it, and this other problem to it. And pretty soon, this diaphragmatic problem is a part of a lot of different problems. It's a part of a large postural adaptive uh, programming in your body that's aberrant and is suppressing your ability to thrive, right? And that's exactly the point is, yeah, it makes functioning very difficult. And you see
For
people later in
sure.
life just having all sorts of problems. They'll start having balance problems and neck problems and chronic back problems. It's like, yes, it's exactly these things that you know, it's not that they can't be seen. It's that we have all these medical tests that show fantastically wrong things. But they don't show just like simply wrong things. And this is one of those simply wrong things that has just a huge effect. And again, because you breathe 23 to 32,000 times a day, every day,
Right.
mostly,
Yeah.
hopefully.
I mean, I think it's important to talk about your approach, your treatment approach, your treatment model
Yeah,
and philosophy, because that's what differentiates you from traditional medicine. And I
yeah,
think people need to see that contrast so that they can understand, well, I do need to incorporate this osteopathic stuff into my healthcare. I don't know. I don't want to call it
regimen,
routine, but healthcare
regimen,
regimen.
yeah,
Yeah. So that I can get the most out of what's available,
right. Or if
so I
that,
can, so that I can thrive.
right, exactly. When traditional medicine doesn't have an answer for you, don't throw your hands up and say, okay, do the surgery or just put me on drugs. Because people they want to live their lives, but they're trapped. They don't know that there might be something else that can help them. And that's the sad part of it is the traditional medical system's kind of saying, nope, that's it. That's all we got. It's either this or this, or
And on paper you look fine.
yeah, yeah, you look fine to me. Meanwhile, the person's, struggling and it causes it, it just makes people feel bad. They don't enjoy their lives. And that's sad. That's not what that's not what anyone intends with their life is to be miserable. So,
Yeah, I think Autumn's told me a few times about patients who have had that experience with traditional medicine where the doctor's like, "You look fine to me," but people, some of our patients know, well, I'm not fine. I don't feel fine.
or even
And
worse,
sometimes,
well, go ahead.
sorry, go ahead.
So, or even worse, the
Oh,
doctor says you're crazy. Take some medication.
yeah, right.
Yeah, even worse. I mean, that's the penultimate worst. Like, wow, not only did your healthcare professional not help you, they've actually given you a diagnosis that's harmful to you.
Right. Yeah, it's pretty wild. Yeah. But yeah, I think this was good. I think
Well, should we do a couple of these
trying to
where I
think of
take like an injury and a patient and kind of tell the story? Obviously, it needs expansion on, like you said, like integrating the osteopathic part and saying, okay, let's add more into that. Um, because it,
Yeah, I think your experience is kind of like a I want to say a high level view, maybe. It's
yeah,
kind of, I don't know, maybe I'm trying to think of what to say. But you're kind of looking at it at a high level, you know, th- but we could dig a little bit deeper and kind of expand it to how it applies to the osteopathic model, but also how maybe, like we touched a little bit about it on this episode about how the diaphragm not only affects your breathing, but it also affects fluid flow
right, right,
and
yeah,
things like that. Like the liver, how it twists, kind of wrings the liver out and things like that. I think I really enjoyed that. I thought that was
yeah.
fascinating. I don't
Well,
I don't
yeah.
think a lot. I mean, who else in medicine knows that kind of stuff? Like,
There's the sad thing is like, I mean, I think technically, like if we sat here and had this conversation with many different healthcare practitioners, a lot of them would chime in and say, yeah, yeah, actually, yeah, that's right. I do know that. But right, but does it come out in how you treat the patient, or does it come out in, or or are you just hoping, right? I mean, we all kind of hope, right? I mean, like you do something, we all like, I hope this makes a difference. But sometimes the doctor says, well, look, I did this, and I was just hoping that you'd start working right again. We want to take away the hope part of it and make it more of a let's make it work. Let's provide it a conduit, an immediate conduit. Let's remove every little barrier that we can, as opposed to like kind of like, hey, throw the bird up in the air and hope it flies. It's like, well, it
yeah,
doesn't fly. It's going to be ugly. Yeah. So
right. And that's because, you're able to see the signals that I think so many, I mean, traditional medicine I think they can see it like in its own channel, but they don't integrate them. You know,
right, right.
like neurologists, they can see bioelectric signals, and you know, doctors can see biochemical things and biomechanical things, but they don't integrate it. They don't, right?
Yeah.
They
And they don't.
they just hyper focus.
Well, the
This is that six
mechanical,
inch box that you talk about.
right? They just have that 6 inch box, and they don't think the mechanical part of it, right? They're so into the bioelectrical or so into the chemical that they can't see that like Yeah, but those aren't separate charts. Like we, in medical stuff, you have charts on the wall, and you usually have the charts on the wall of the things you treat. And so doctors often have organs on the wall, or nervous systems on the wall, or lymphatics, or whatever. But in my office, I have all the charts on the wall because every one
Yeah,
of those charts is overlaid and inlaid with the other one. It's like it's not like when you touch something, you only touch one of the charts. All the charts are being touched at the same time when you do that.
right, right.
And it really shows you if you're
Yeah,
doing a change for example, like, and I'll use this next week with the psoas and the hip. I was going to do hip next. Um, but that, like, for example, if the psoas, you might go back and restore a hip function, but that changes how the pelvic floor works. The psoas actually inserts through the diaphragm, right? So it goes all the way up to the diaphragm. You would think, I have a hip muscle that goes all the way up into my diaphragm. Yes. It also helps drive fluid out of the abdomen, right? Because uh, it's like your washing machine. It turbinates or turgenates, right? It's like it drives fluid up through your abdomen, out of your leg, into your abdominal contents, out of into your pelvic contents, out of your pelvis and into your abdomen, out of your abdomen and into your chest. So here's this hip structure that sometimes people fall and break it, or they have whatever problem, but it just has such an effect in so many different directions. There's lots of new information out there. I mean, it's old information. I mean, this information isn't new. Humans have been using their diaphragms to breathe for a really long time, and uh, doctors, the osteopathic tradition goes back to the late 1800s. So, yeah, this has been going on a long time, but maybe the knowledge of it and the breadth of the problem isn't known. Okay,
yeah. I think the approach too, and I think we've talked about in other podcasts how there's such a specialization these days in every industry, and healthcare is no exception. And just how medical professionals in traditional medicine they're just hyper laser focused on one organ or one system of the body, which is not, there's nothing wrong with that. But what I
yeah,
really appreciate about the osteopathic model is how it looks at the entire body. It's an integrated system of lots of different things, and like you said, restoring the diaphragm movement, it affected your patient's back. Being able to breathe affected his ability to move and get off medicine, and it's just all these things are interrelated. Your breathing, your movement, your body
blood pressure.
structure, the way your posture, how it affects everything. So that's one thing about the osteopathic model that I really appreciate is how it looks at the entire body as an interconnected uh, set of systems.
Yeah, no, entirely. I mean, and that is its strength, is that it brings everything together. And while we need specialists to focus in very closely on things, the problem is that there's a couple different forces working on the medical system, and one of them is profitability. And when people are demanding that there be high profits, there's no extra time for anything, including sometimes doing the basics. I mean, and for clinicians listening to this, never skip the basics. You notice I just went back to the basics, ABC, and
Yeah,
even in
ABC. Yeah,
yeah, even in advanced care, simple mechanical assessment often reveals what imaging cannot, right? Sometimes restoring motion is the missing link between survival and recovery. And as you said, thrival. Can the patient thrive? And that is the strength of osteopathy. Its goal is the overall function of the person and the overall health of the person, and how do all the individual medical things come together to make that work, right?
for sure.
Yeah. So so there's the thing. I mean, this coach came in, mostly unable to breathe, and he left breathing freely. Just reminds us that healing isn't always about the complexity, right? I didn't do something massively complex. I just looked at his ability of his rib cage to move, his diaphragm to move, which, like we talked about, that changed his neck, that changed his posture, his throat, the hoarseness in his throat, because he had been in ICU for so long. He had a tube down his throat for weeks, a couple weeks actually, and so his throat had just been really raw, and he had talked about how much pain he had just swallowing, eating, all these things that just he couldn't really enjoy his life, right? There was just nothing enjoyable. He was miserable because he had lost his wife. He was miserable because everything hurt. And yet medically, they're like, well, you're on the level. We've done everything we can. There's nothing more to do. Um,
Yeah, and
so,
according to our images, all your structures are healed. There's no bleeding.
right,
And this is what I'm guessing that they said. And
right.
I'm sure his labs were all within acceptable limits, and
Ranges.
so
Yeah.
yeah. So on paper he looked recovered.
Well, and that's just it. So, and the thing is that, patients come in with this all the time, like I was saying, and that uh, you have people who have fluid on their abdomen, and then they're talking about, oh, I have gastrointestinal distress, or I have this, or I get a lot of reflux. It's like, well, if you have back pressure on your organs because of fluid in your abdomen, and all that fluid has to traverse the diaphragm. So if the diaphragm is under tension, there are these structures in the diaphragm called stomata. And stomata are just little openings that let fluid in or out. In plants, there's stomata that let water in or out, or carbon dioxide or whatever. Um, so the human diaphragm has stomata in it, and what its job is to take fluid that's in the abdominal cavity and move it into the chest cavity at a measured rate, so that you don't overwhelm the chest and compress the lungs and the heart, but at a measured rate that it can be absorbed and then pushed into the thoracic inlet, which is the way that it gets back into circulation. So the whole body is draining up through the lower body, up through the diaphragm, up through the chest. Does tend to concentrate into the left. 3/4 of the body drains to the left. 1/4 of the body drains to the right, though the heart and lungs and the intestinal viscera themselves drain to the right. So you can see that's maybe a balance. So this diaphragm has all sorts of you know, it has all sorts of function there that you might not even think of, like there's fluid drainage. Also, the diaphragm, one of the important things to understand about the diaphragm is it's not a one-sided pump. Everybody thinks, oh, we breathe with the diaphragm. Yes. But what does the diaphragm do on the other side? It actually pushes down on the intestinal tract and squeezes that very fluid I was just talking about. It squeezes that fluid out. So what's the function of the liver? So when people have uh, fatty liver syndrome, right, or fatty liver disease, uh, if your diaphragm does not have proper excursion, that's going to be one of the reasons that all that oil, right? When we say fatty, we mean oil. There's oil in the liver. One of the reasons that oil is not getting expressed out of there, drawn into the lymphatics and dealt with, because the lymphatics deal with fats such as oil. That's why we call it fatty liver. Uh, you're not even expressing the oil out of the liver. So one of the functions, now I'm not saying that this is like a cure for fatty liver. That's not what I'm saying. Obviously, there are other things going on, but in order to make the medical treatment for fatty liver more effective, we need the diaphragm to be able to squeeze the liver and
To
move
squeeze.
that oil out. Yeah, right. I mean, it just kind of sounds crazy. It has to push down on that liver, and of course, the liver does move with the motion of breathing. But it also, because it's in a bag, right? It has a capsule around it, if you will, and that capsule is attached up uh, at either side of the abdomen there. And so as you breathe, the liver is moving at an angle, and it twists the capsule that the liver is in. So in other words, it's somewhat like wringing a towel out. So just the action of a
That's
full breath.
crazy.
Isn't that crazy? Yeah. It's kind of like, oh,
Yeah.
yeah. But just that action helps push that oil out of the liver, right? And then pushes that into the lymphatics. The lymphatics are who deals with oil. They'll help break it down as it's going through lymph nodes and lymphatic ducts. Obviously the liver is one of the big places you want to do that, but sometimes the liver's over challenged, and so it gets backed up. Maybe you had, for whatever reason, there's a heavy load on it. But again, if you get fluid moving and you get the kidneys involved and you get more immune cells involved, more macrophages involved, you get more parts of the body involved in breaking things down and processing them. Um, then the liver has an easier time. So the better fluid flow through the liver, the easier time the liver has to do its job. Well, here's a case where just a simple problem with a diaphragm is exacerbating serious medical conditions, right? So even just as a finesse, or let's make this easier on the body sort of thing. If we could reduce this 5%, 10%, I think most people would agree that if they were in discomfort, right? And a lot of times fatty liver is uncomfortable because of the pressure in the abdomen. If you could take, 10% of that away, people would be pretty happy with that. And that's without
Yeah,
medical
for
treatment.
sure.
Yeah. So again, back to the coach, he's just a great example of someone who had he had a traumatic aspect to this. And there's the thing: people get in car accidents all the time. They go, "Oh, I was fine," but that doesn't mean that you didn't uh, flip your liver and yank your diaphragm and cause something to happen to it, because your abdominal contents, they're not locked into your back. They're in there on fluid pressure. So even when you get in a car accident, your liver actually tends to flip forward because of the weight of it, the pendulousness of it, and that will yank on the diaphragm. Well, then that yanking might cause the diaphragm to stop working on that side as well. Won't stop it completely. You won't feel like, oh my gosh, I have a lung that's not working, but it will just decrease its efficiency 70, 80%. You can actually see when you do the test, you'll see how poorly one side will go down. You'll say, wow, that pretty much stays up the whole way. Right. And that just, it reveals to you how much dysfunction there is in the diaphragm, and then how that's going to affect all these other organs. So falls, car accidents, but even, actually, it is cold and flu season here in the Northwest. And so I have lots of patients coming in. They've been coughing, they've been sneezing. And guess what? The diaphragm gets involved and then gets locked up, and so it can't do its job as well. And so then their recovery from their flu or their cold is held back, because now they can't breathe, pull air, oxygen into their lungs, or air into their lungs. And by not, and same process as the liver. The lungs are attached by, there's a bag around the lungs, and it's attached up superiorly, more at the neck, and obviously it's adhered down. The lungs are adhered down to the diaphragm on top, or what we call the pleura, the bags around the lungs, are adhered to the diaphragm. And when the diaphragm has full excursion, it stretches those bags and squeezes everything in them out. And when it lets go, it lets them suck up fluid from the surrounding tissue. And then, so that pumping action, it's multi-level. It's not just creating a vacuum so that air gets pushed into your lungs. It's also stretching the structures, whether those are your chest structures, like your lungs or your pericardium, or your abdominal contents, like your large intestine, your spleen, your liver. It's a multifunctional organ, that it does a lot for us that we might not even realize, or. So it's very important for people to understand, like, if you're having problems, like, oh gosh, when I get a cold, or I have some problem, I can never seem to recover. It takes me forever. That's exactly the kind of patient that we have coming in, that we say, look, we need to let's look at your diaphragm. Let's make sure that your diaphragm, and then the diaphragm's adhered to the rib cage. So we have to make sure that the rib cage and the thoracic spine work properly. There's not a whole lot of treatment in the traditional medical model of the thorax, of the thoracic spine, of the ribs. Um, Nobody really gets too concerned about that, and that's unfortunate.
Right. I was going to ask you if you could maybe go into a little bit more detail about what is it about repetitive coughing that causes the diaphragm to get stuck?
Yeah. So, anytime you use a muscle, it's somewhat like doing a biceps curl. But instead of doing a full biceps curl where you completely straighten your arms and then completely bend your arms and then completely straighten your arms, where the muscle gets stretched out, a cough, and especially when you get, like, say, a coughing fit, the diaphragm will flex, but it will flex and then in short order just flex really hard and rapidly in a short position. Well, we've all been to the gym where the guys have done too many biceps curls, and they're walking around with their hands halfway up their chest and they just can't straighten out their arms. Well, right? Well, guess what your diaphragm
Yeah.
looks like? It looks like
Okay.
that muscle guy, which
It
then
just retains kind of like a tenseness to it.
exactly.
It's not able to extend all the way.
Right. And then it needs some sort of release. And then, even though, you keep using your arms, and you say, well, eventually, yes, but you can ask anybody who lifts weights, they always have a knot down by their elbow, right? In the biceps from doing bicep curls. And
Hmm.
straightening their elbows completely is really difficult for them. Well, I don't breathe with my elbow. So me losing 5 or 10%, okay, whatever. But if you've lost 5 or 10% of the function of that diaphragm, or 30% on one side, and then that, again, breathing 23 to 32,000 times a day, causes you to bend towards that side, so that the level of pressure on both sides is even, right? You're going to move your thorax to even out the pressure from one side of the diaphragm to the other side of the diaphragm. So now your posture's altered. Well, now how do you breathe? How large can you make your chest? Because uh, if you don't get enough oxygen in, you don't break down those products that the cough or cold or the virus or the bacteria have caused you, right? So it just becomes this
Hmm.
rolling bunch of errors that start, like, little things that don't seem to matter too much, just start rolling into a big ball of of destruction. and dysfunction.
Gotcha. All right. Thanks for that explanation. I don't want to turn this into an ad, but I do want to ask you, you mentioned a lot about the diaphragm, but I want to ask you, in which class that you teach, do you kind of dive deep into the diaphragm and how it relates to maybe the thoracic spine and your rib cage and things like that? Just in case anybody's interested, what would they get out of a class where you talk about treating the diaphragm and the structures associated with it?
Well, as we talked about, there's so many different areas of function. So certainly in our baseline classes, we have a class about the thoracic spine. So it's the thoracic spine in posture and gait. The diaphragm is the halfway point of gait, of walking, in a movement, and of breathing, and just of posture. Like, what's your static posture? People who wear out. So people who start getting neck pain or back pain or whatever problem, and they can't sit for a long time at their desk, and they're saying, I'm having all sorts of problems. The diaphragm functions in that. And so that it's included in that class in that fashion. And then we have a class on visceral mobilization, how to make sure that the intestinal organs are able to move. Actually, we're not just intestinal. We have one on the intestinal. So that's visceral 3 is the subdiaphragmatic organs and their motion. We also have visceral 2, which is supradiaphragmatic organs and their function. But of course, there's a reason we say supradiaphragmatic and subdiaphragmatic, because no matter what, we're going to the diaphragm because it's so important. Yeah, so either of those classes, we actually have some classes that they'll have the name diaphragm in them, where we're specifically in, let's look at everything the diaphragm does. So we have some focal classes on the diaphragm itself. Usually we put it in the context of how is the diaphragm a part of the working whole of walking, of posture, of this. So you'll see it in almost any class that deals with that thorax. You'll see that in the name. But those are the 3 main classes that we deal with the diaphragm. We also have a class
Awesome.
called
Very cool.
5 diaphragms. So there's more than just
5
one
diaphragms.
5 diaphragms. I think of the pelvic floor. The pelvic floor and the respiratory diaphragm have to work together. So there's 2 of them, right? You have a thoracic inlet or a thoracic outlet, as most people know it. That's a diaphragm. So there's 3 of them. Base of the skull is number 4, right? And you actually have another one down in your foot. So that's the 5th one. And if your foot doesn't pump, then you build up fluid in your leg. So understanding how these diaphragms work together, it's a useful concept.
Very cool.
All right.
Awesome.
Yeah. So there we go. So hopefully, those classes are available for sale online, and that way, even lay people are allowed to watch those, so that they can maybe gather information and learn more about that. Or if they have a practitioner that they know that might be interested, the practitioner can go on the website, pursuitpt.com. Look at our classes. There's a members website area. Click on that. Make a membership and sign up. And then you can go through and look at the list of classes, and there's a description of the classes. They can sign up. So hopefully that information finds its way to people who are in need.
For sure. All right, Neal. Anything else we need to discuss?
No, I think that's it. Thanks for listening to OsteoSignal. If today's episode helped you understand your body a little better, share it with someone who might benefit. And if you're a clinician wanting to deepen your understanding of how structure, motion, and signaling drive recovery, stay tuned. We have many more stories and insights coming. We're going to do, come check out our podcast. We've got lots of information and love to share it. So until next time, keep listening to the signals your body is sending.
Thanks for joining us on another episode of OsteoSignal with Neal D. O'Neal. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D. O'Neal.